the heart.
Thank you very much, Joe, Dr. Angelini. It's a pleasure to follow my distinguished colleagues and friends. Definitely one remark about the previous talks. I think you're all right in what you've mentioned. We really need a randomized trial because, as you said, if it's 5–10% of patients who receive BEMAs, inherently there is a selection bias right from the start. Who are these patients? Why are they receiving it versus the 90% who are not? Are they because they're operated by a better surgeon or a center that will provide more care to their coronary surgery, or is it better they're perceived to be healthy and have a potential for long-term survival? So I think that is the potential for confounding by indication is definitely there at the source, especially when intervention is done so infrequently. So this talk did not come from my own choosing. I was given this title, can a single ITA composite graft adequately supply the heart? I do both, and I have my views about this. I'm going to try to present to you the evidence as it stands right now. I have incorporated content from my colleague David Linner, who is also starting in Ottawa this very month as one of our new recruits, and we're very proud to have him. David has studied this in great detail from a physiologic point of view. So what are the pros and cons of using a composite graft, either built with a radial artery from the left ITA, the right internal thoracic artery, or also, as you know very well, a saphenous vein? Well, the pros are that there are no aortic manipulations, and I think this is probably what leads to most of us doing this. There's also ease in doing so. Once you get used to it, you get definitely greater conduit length and you get more arterial grafts. You don't need as much lethal length, and you can do serial anastomoses with it. From a RITA anastomosis point of view, there's much lower wall tension. You don't have to connect it on the aorta. And this wall tension is not only problematic. I tell my residents and fellows that this is one of the most stressful anastomoses that we can ever do, which putting a RITA directly onto the aorta. I often ask the anesthesiologist to bring the pressure to 160 to make sure it doesn't blow on you. And I think all of us who've done it know that once in a while it's very treacherous and it will do something funny to you. So I think from a healing and wall tension and intimal hyperplasia point of view, it certainly is not optimal. And the patency results appear to reflect this, as David was alluding to earlier. And another nice aspect is that there might be, especially with regards to saphenous vein graft, there may be an elution of nitric oxide that occurs from the left internal thoracic artery into the saphenous vein, which otherwise would not take place. And finally, one other advantage is that there are no crossing grafts. So especially I tend to do this systematically in patients who have mild aortic stenosis who might have to come back or some other issue that increases their likelihood of reoperation in the future. But the cons are that it's a single blood supply, and I think that's what we all worry about. If you were to have a problem with the anastomosis, not so much acutely, but perhaps development of intimal hyperplasia, we know that an 8-0 proline is not necessarily something that the vessel in the intima needs to have in the middle of its course. So we don't really know how this will heal in the long term. There's also a steal potential, which has been well studied, in part from David Linner's studies, and I'll show those to you. And it's also not nearly as validated. I think the trials that have studied coronary surgery versus stent and PCI outcomes have used lethal plus 2s with independent grafts. So there are some horror stories. I want to relate to you this study that's now over 10 years old of 25 patients who received a composite Y internal artery saphenous vein grafts with very poor angiographic results at a mean of 2.5 years. Essentially, in this study, the mean perfect patency rate was 72% for all grafts, and most of the issues were actually seen with the distal ITA graft and not with the saphenous vein graft. In fact, only one saphenous vein failed, but the distal ITA had a tendency to go into a string sign, as can be seen here on this picture from the paper. However, it is certainly a very instrumental way to do things. Composite grafts allow you to do total arterial grafting, 3-4 grafts very easily. And I think we have several examples of this. These are very regional practices. Korea likes, this is very diffused. also Belgium, France, I think in the UK as well, and in several centers in Japan, in Europe. Not so much in North America, except very small isolated pockets. And in this series of about 512 patients from Dr. Kim in Korea, the event-free survival at 5 years was fantastic in reaching almost 90% at 5 years. So pretty beautiful results, and certainly a very well internally validated technique. We've seen before from Dr. Angelini the SAVE-RITA trial being quoted. In this trial, the comparison was between a Y graft made with the right internal thoracic artery attached to the left versus a saphenous vein graft. And the results were equally amazing in both configurations. This is an example of an early and 1-year angiogram of a patient receiving a saphenous vein graft, anastomose to the leta. Now, I'm sure several of you in the room would never do this to your patient, but in fact, there's quite a bit of indirect evidence now supporting that in selected centers and with selected techniques you can have extremely good results, as was shown at the ATS a couple of years ago by Dr. Kim, and the paper is now out on this. And again, the patency rate was in excess of 95%, regardless of whether configuration used the right internal thoracic artery or the saphenous vein graft. So things seem to be really turning up for composite vein grafts, but this is a picture of me with my first girlfriend. They're not always as perfect as one initially sees them. So there are controversies, and I think that what we worry about is the maximum lethal flow sufficient for all myocardium? And also, could there be a steal phenomenon from one graft to the other? What's a steal phenomenon? It is the diversion of blood flow from a high resistance medial to a low resistance branch during hyperemia. And there are ways that this can be tested. So what do we have in terms of theoretical background? You can measure intraoperative flows in both limbs of T-grafts. And these have been done before. Affleck and Al in their group have looked at competitive flow at the time of the operation. They found that there was a 1.6 flow reserve ratio, which is quite sufficient, and concluded that T-grafts were sufficient to feed the entire left heart. Now, you can also use a Doppler guide wire, and this has been done in the context of T-grafts with radial arteries as well as betas. And in the time frame of 1 and 6 months, and these have shown that in fact there's a tendency for the flow reserve to increase over time, initially from numbers of 1.8, so close to the 1.6 that you saw in intraop, to about 2.7. This is due both to a slight decrease in baseline flow and a slight increase in maximum flow, therefore a favorable evolution over time. There's also conflicting results very early on using PET scanning and looking at regional myocardial blood flow reserve. In fact, this study from Sakaguchi looked at 2 weeks post-op, and patients were actually having lower flow reserve in a Y graft configuration than if they had independent grafts. However, this doesn't tell us really, is this due to the conduit size, which acutely we know may not always be sufficient to meet the highest demands of the heart. And we've seen from other studies that the flow reserve tends to increase with time. Or is it really the influence of the coronary arterial bed and a potential steal phenomenon? So this was studied in a couple of papers by David Linner, first in Circulation in 2005, looking at the resistance of 11 patients who were asymptomatic, who were 6 months after beta grafting in a Y configuration, using pressure and fractional flow reserve. In fact, the two are related. The fractional flow reserve is calculated from the pressure distally where you want to measure it at a particular level of the graft, over the aortic pressure, which for the purpose of the study was equaled to subclavian arteries pressure. So it is the index of these that give the fractional flow reserve. So the wire, which is a small 0.14 wire, can be inserted and left in the subclavian artery for the proximal/aortic pressure measurement, can be brought into the circumflex artery for the Y graft distal pressure measurement, or it can be left near the distal LAD anastomosis for the distal LAD measurement. So the flow reserve can be computed from those. So to look at maximum hyperemia and to induce potential steal, a bolus of adenosine 40 micrograms is given classically, and then the pressure is measured based on this. As you can see here, you have baseline conditions, and then looking at distal pressure after a bolus of adenosine, which varies between the aortic, which is the black line, and the red line being the distal LED pressure. So an example of this here, where the graft configuration is seen and the wire can be advanced in either limbs of the Y graft and the pressure measured as such. So the results that you get are quite detailed, and this is quoted from the paper. So this is in the ITA main stem compared to the subclavian artery after a basal conditions and adenosine bolus. So in this case, at basal, the conditions, the pressure drop is very small, 2 millimeters of mercury, and goes up to about 6.5 after 40 micrograms adenosine bolus. Now in the distal LED, this goes from about 3, which is slightly statistically larger than 2, but clinically not significant, and to about 9 in the distal LED bed near the anastomosis. And with regards to the circumflex, that also goes from about 3 to 8.8. Computing those ratios and putting them together in terms of obtaining a fractional flow reserve, one gets in all cases a slight drop with regards to the distal LED compared to the circumflex. But again, as you can see from this slide, a flow that remains well over 0.8. If we use a cutoff of 0.7 or perhaps a very restrictive cutoff of 0.8, we are still well above that level in all cases. So in their studies, they concluded that the Y graft configuration allowed for adequate revascularization and equal distribution of perfusion pressure in both distal branches of the Y limbs. Now, looking at comparing in a more ambitious study a saphenous vein to the right ITA being in a Y configuration, they continued with 17 patients who were asymptomatic, and they followed them 3 years after their Y graft configuration using the same type of tools. So the mean number of anastomoses between the Rita and saphenous vein graft was essentially statistically identical, although there were a few more numerically in the saphenous vein graft group, 1.6 versus 1.2, so 1 or 2 marginals being grafted. And the number of Lita anastomoses was also more in the saphenous vein graft group. So the degree of stenosis severity was comparable between the two, with the exception perhaps of the degree of stenosis on the OM2, which was less in the saphenous vein graft group, 54% versus 73%. And what's interesting to see here is that they measured FFR and they also looked at graft size. And as one would expect, the distal limb of the Lita LED was slightly smaller in patients who were Y-grafted with a saphenous vein graft versus a Rita. You can see here 2.2 millimeters versus 2.5 millimeter in terms of graft size. And comparably, the limb going to the circumflex was, as you would expect, larger in the saphenous vein graft configuration than with a Rita Y graft configuration. This translated in small numerical changes, indeed showing this is the results for the Rita Y graft, showing a dip with regards to the distal Lita LED, but which remains well above 0.8 at all stages. Now that dip is a little bit deeper when you look at the saphenous vein graft Y configuration going to the circumflex, but again, it remains above 0.8 in all patients. So essentially no differences between the two. So all FFR values were above 0.7 and even more above 0.8. And there was essentially similar and adequate perfusion of the left system with minimal resistance to maximum flow and even distribution of flow between the two. So I'll conclude by saying that composite Y grafts appear to yield early and midterm results that are equal to those of independent grafts. However, we must be careful. I think before we put all our eggs in the same basket, we must know that long-term outcomes are very scarce, except for very isolated, perhaps internally valid, but not yet externally valid series. And that nearly all trials of coronary surgery, either comparing it to medical therapy or to PCI, have used classic, quote unquote, cabbage configurations with independent grafts. I think there is definitely a potential for endothelial hyperplasia as a nidus for atherosclerosis, as we all know it can be. And this would have disastrous consequences, such as the loss of all grafts, potentially in some patients with time. There's also really a potential for publication bias, and I think some technical considerations that I did not go into today, but I think it's very important to have your proximal source size as proximal on the ITA as possible. So when one is talking about minimal invasive cardiac surgery and doing a fairly distal Y graft on the left ITA, I think this may have different implications than doing it very proximally, as the size of the ITA is different between the two. It also goes with operator experience, and I think one thing that we often fail to mention is the site of harvest of the saphenous vein. Dr. Kim from Korea in the SAVE-RITA trial was using saphenous vein from the lower leg, and I think that may make a difference versus a large, almost varicose proximal thigh saphenous vein. These remain unknown factors. So I think a word of caution, but certainly some good data supporting the use of Y-graft configurations. This is Inuktitut, which is an Inuit language in Canada. It means thank you for your attention, and I'd like to, I'm very grateful to the Society for the privilege of presenting today.